Good afternoon. I'd like to extend my welcome to the Royal Aeronautical Society for our Mental Health Awareness in Aerospace event. And for those who are able to join us in person, welcome to 4 Hamilton Place. And I'm delighted to say we have a large number of people online as well. You're equally welcome. I'm Alistair Wood. I'm the president of the Society for the 25-26 year. One of the benefits of being president is I get to influence the Society agenda. And I have 2 main themes: people in aerospace and safety enables, recognizing that the 2 are actually interrelated. I'd like to start by saying a few words about the Royal Aeronautical Society, the only global organization serving the entire aerospace, aviation and space community as both a learned society and a professional engineering institution. As such, the Society is independent, evidence-based, authoritative, relying on a body of knowledge going back more than 150 years and our entire history. It plays a leading role in influence and opinion on aerospace matters through various means, including publications, social media channels, interaction with government, and an extensive events program, including this conference and event. If you are not a member yet, I encourage you to think about it, and I believe our membership team will be around later on. With World Mental Health Day coming up this Friday, this event is a timely opportunity to bring our community together to focus on mental health and well-being across the sector. While there has been an increasing acknowledgement of the importance of psychosocial risk management, mental health support, there is still plenty of work to be done. Together with our event speakers and experts, today's event aims to raise awareness, share experiences, and highlight the resources and support available within aerospace. By opening up conversations, leading from best practice, and engaging with expert perspectives, we aim to encourage a culture where mental health is recognised, understood, and supported as much as physical health. I'll now hand over to Mark Atherton, registered aviation psychologist and member of the Society's Human Factors Specialist Group, for some context. Mark.
Oh, thank you, Alistair, and thank you everybody in the room, and thank you to everybody online for joining us today. Today's event is the latest in a series of events going back almost 10 years at the Society, promoting the concept of mental health and well-being as a key safety enabler in the industry. If I go back to the first conference we organised, I proposed it, and the response from the Society was, what? It was not a topic that was on anybody's radar. That slowly changed, and I'm proud to say the Society has been part of a sea change in the awareness around the importance of mental health and well-being as a component of a safety-focused global industry. We can go back 2018. EASA produced what's commonly called their mental fitness rule, psychological assessment, peer support. We have, subsequent to that, the FAA with their ARC on mental health. EASA produced their MeSafe program. Recently, the FAA have, or the US government rather, have signed the Mental Health in Aviation Act into law, which is relating to primarily pilots and disclosure and management of mental health conditions. ICAO recently accepted a document from IPAC, the peer support collaboration, to cement peer support as an element of a process of ensuring mental health and well-being. So where we are today is at a juncture where there is a significant movement globally considering mental health and well-being. The challenge, as I see it, is coordinating all of the various activities and initiatives to make sure that as an industry we come together to promote best practice, and efficient and effective means of supporting the mental health and well-being of all of the safety critical stakeholder groups, not just the pilots, engineers, air traffic controllers, maintenance organisations, airports. The staff of all of those organisations not only warrant individual support, but providing it guarantees the minimum risk to our operations as a function of poor mental health and well-being amongst our workers. So today's exercise is to bring some expertise and some perspectives to that issue from a number of very well qualified people, and hopefully we can contribute to and continue the dialogue of moving forward with producing a culture of positive mental health and well-being which support both operational safety but also the well-being of the individuals that make up our industry, whichever safety critical stakeholder group they are working in. So that's the backdrop to today. What I would like to do to open the session is to introduce Professor Derek Tracy. Derek's the Chief Medical Officer of the South London and Maudsley NHS Foundation. And he's going to be talking to us about supporting the mental health of mental health professionals. It's a crucial aspect of maintaining a systems operation. Professor Tracy is the Chief Medical Officer and Executive Director for Psychological Therapies at South London and Maudsley NHS Foundation Trust and Deputy Chair of the Cavendish Square Group of London CMOs. Derek is an adjunct professor at the Institute of Psychiatry, Psychology and Neuroscience at King's College London and an honorary professor at Brunel Medical School. His PhD was in policy and cultural aspects of creating better integrated care systems, and he has a particular interest in the measurement of clinical effectiveness in large-scale healthcare organisations and cultural factors that support staff. He's published over 150 peer-reviewed articles, and other research interests include new psychoactive substances, legal highs. Derek is a member of the Advisory Council on the Misuse of Drugs that advises the UK Home Office on drug harms. He's a deputy editor at the British Journal of Psychiatry, writing its Kaleidoscope and Highlights columns. Derek is an editor of the leading UK textbook on the Coroner's Court and the forthcoming Royal College of Psychiatrists book, Research Methods in Mental Health. At the Royal College of Psychiatrists, Derek is an executive member of the Occupational Psychiatry Special Interest Group. In 2020, he was co-opted as one of the medical leads to design and run the mental health team at the London Nightingale Pandemic Hospital, work that was awarded the 2021 Royal College of Psychiatrists Team of the Year. Other notable awards include the 2024 Royal College of Psychiatrists President's Medal, the 2019 Royal College of Psychiatrists Communicator of the Year, and the 2015 King's College London Teaching Excellence Award. I think Derek may have a few things to teach our industry in terms of how we consider, measure, manage and mitigate mental health challenges. Derek?
Thank you, it's a pleasure to be here. Am I advancing my own slides? Oh. Thank you, it's lovely to be here. Thank you to my mum for doing that bio, that took so long to read. I'm going to talk through a few different bits. I'm going to talk about my industry, so this might be slightly sideways to you, but hopefully there's lots of relevance. So as mentioned, I'm the Chief Medical Officer of an NHS Trust, so that's my job is to run healthcare. But I also, as part of that role, as well as delivering the strategic plan for that place in South London, I also have to look after my own staff. So it's a really unusual job to look after the mental health of people who look after mental health themselves. So it's a rather expert group. What I'm going to do, I'm going to tell you a little bit about my industry and the pressures we're under. I'm going to take the example of something unusual we did a few years ago. We set up the London Nightingale Hospital, that some of you might have heard of, the pandemic hospital, and the lessons from that, an evidence-based approach to looking after staff. And I'll finish up with some research that we're doing at the moment. So a little bit about us. We're very proud of our history. So we are the oldest mental health trust in the world, the oldest psychiatric hospital. I don't know if any of you have heard of the Bethlehem Hospital. So the word Bedlam comes from this. It's almost 800 years old. It's featured in King Lear. So it's a very ancient trust. That's my current trust headquarters, the Maudsley Hospital there. And we are the largest centre of mental health research in the world. I'm very proud of it. And we are the largest provider of national and specialist mental health services across the UK. So it's a big organisation, lots of staff providing lots of expert care in mental health. My industry, I won't dwell too long, don't worry too much about the detail on that. For me, the problems are as follows. So the population of the UK is going to grow by about 4 million in the next 10 years. The number of people over 65 is going to double, and the number of people with 4 or more health conditions is going to quadruple. So one of the great benefits of the NHS is it has stopped people dying, but now we have to look after them. And that's really, really challenging for us. And it's putting huge pressure. So need is increasing in my industry. Finances are not matching it, and the workforce is not matching it. So if I'm feeling a bit cruel and I'm talking to our junior doctors, I tell them that they are currently working in what they will come to call the good old days of 2025. Remember how quiet it was in 2025, because need is going up. Mental health need is going up, and we're not going to match in terms of finance. It's hard to predict 10 years from now, but it doesn't seem like we're going to, and certainly we don't have the workforce to approach it. So we have a metaphorical gun to our head to act differently, but actually there's a philosophical driver. There's a big revolution happening in healthcare services around the UK towards more integrated services. So it's a very quick example. The figure on the right, again, don't worry about the detail. Healthcare services have typically looked in at the individual. So the things that make you you, your genes, your ethnicity, your sexual orientation, whatever it is that makes you. But we know that the further we go out, if we go like concentric circles on an onion or a circle out from people, you go from you to you and your family, to you and your community, to where you're working, to you and your country. The further out we go, the more impact we have on people. And services are currently trying to reorientate to work further out into people living their lived lives in their communities. So as an example for you, loneliness is worse for your health than smoking. And we tend not to prescribe friends very often. But what is it that we could do within mental health, but in healthcare more generally? Your boss has a bigger impact on your health than your doctor does. And of course, the further out you go, you get things that are outside your control. So on the left-hand side, you can see what the King's Fund called the 4 pillars of health. So one of them is an integrated health and care system, which is where I work. But there are things I can't do. I can't give you a job. I can't change your education status. I can't say there's going to be war in your country. I can't impact climate change. So you can see there are limitations, and healthcare teaches us some humility. But certainly we're trying to reorganize how we work. But it's very, very difficult. And I have very stressed staff who are working very, very hard all the time. If you're interested, these are academic papers. They may not be of interest to you. On the left is a description of how we're moving into integrated care systems. It's some work we've recently published. And on the right are my immodestly titled paper, The Future of Mental Health, but putting forward some of the ways I think we're going to have to try and deal with that. Next part, so that's the kind of context of the industry in which I'm working. The next part is thinking about how do I look after my staff in what's incredibly hard times. And going back to 2025 being the good old days, those times are going to get harder. So I'm going to talk for a few minutes about something unusual we did about 5 years ago, when we set up the London Nightingale. Do you remember this hospital? The London Excel Centre? So that's me 5 years. I had no grey hair. I was looking at that picture the other day. I've aged rapidly in my current role. And that was our team on the left, and on the right is the Nightingale as it was being set up. And this was in the spring of 2020, when you might remember that wave of pandemic was coming across. Italy was being particularly badly hit, and the hospitals were being overrun. So we were commissioned, at the time it was what was called day minus 21 days before it opened. We had to set up and staff a hospital that would hold 4,000 patients, all on ITU beds, with 16,000 staff. And our job was to support their well-being in what was going to be considered a really horrific time. We expected at the time that there would be a 50% mortality, so 50% of all patients would die. Within the Excel, there was a mortuary that would hold 600 bodies. I think the day I went in at day minus 21 is the one time in my career I felt really, really overwhelmed. You can see on the right, the Army Engineering Corps were laying out the tape. If you walk by the Excel in East London, it's 1 kilometre long. If you want to do a thought experiment, if you walk for 1 kilometre, it'll take you about 8 minutes. And time yourself for that whole 8 minutes, because we did this through the centre of the Excel. For 8 minutes, ward after ward after ward. On either side, you're going 20 deep with ITU machines. And it felt horrific. The mortuary was big enough that an articulated truck could drive around the middle of it. And there was a taxi rank set outside for hearses and ambulances to take in and take out bodies. So it was pretty horrific. We thought it was going to be devastating for staff. And our job was to look after them 24/7, and we had 3 weeks to set it up. And of course, the upshot of it is the Nightingale was never needed in that way, but we didn't know it at the time. And our instructions are pretty clear. On day 1, it needed to hold 6 people. On day 7, 200. On day 21, 2,000. And on day 28, it needed to have 4,000 ITU beds running. And we were trying to deliver a model that was evidence-based and would support people in that environment. And a couple of key concepts. One is called moral injury, which has become an increasingly familiar term for many of you. This is dealing with circumstances for which you feel your training has not prepared you. I don't know how that works in your industry. So for me, my training had never prepared me for 4,000 bedded ITU at a 50% mortality rate. We were fast tracking that summer. Medical students and nursing students, we graduated them all 2 months early. So they hadn't finished their training. We were putting them into new teams where they didn't know each other. But the second really important thing is what's called post-traumatic growth. Trauma is typically unwished for in life, but it's an inevitability of it. Most of the time when you go through trauma or stress, you are not damaged by it, and indeed, you will grow from it. So your mum was right. What doesn't kill you makes you stronger. But you've got to balance both things. Some people are going to be damaged by it, so how do we do both of them? And this is an evidence base. I'm going to put up in a couple of slides some of the papers we've done, and I'm very happy to share the detail, but I know from a timing point of view, I want to get through this pretty quickly. We've only got a few minutes. So there are 3 levels. From an occupational health point of view, one can conceptualize 3 different ways you might approach problems with your staff. So primary prevention, how do you stop problems occurring in the first place? How do you set up a workplace or an environment in which people are less likely to develop problems? Secondary prevention, how do you get in really quickly when people look like they're beginning to suffer stress, when it looks like it's getting on top of them? Before a problem actually fully emerges, but someone's beginning to drown, how do you get in there with it? And tertiary prevention is when someone has a problem. I am now depressed and I need help. And you want to look after someone quickly. The quicker you can treat someone, the better their outcomes, and of course, the quicker we can get them back into work. Our job was to keep that workforce ticking over. The 16,000 staff looking after the 4,000 patients, we needed them as well as they could be. So primary prevention, a lot of it for us was giving good information to people. I don't know what your industry is like. I'm still fascinated in the NHS. I'll go onto a trust website, I'll Google them, and the information's way out of date. The phone numbers don't work anymore. The web links are broken. Primary prevention is having up-to-date information for your people that's valid, that's reliable, that they can trust. It's being frank and honest with people. So at the time when we started Nightingale, it was a voluntary workforce, and we had to have a conversation with them. We said, this is what we think is going to happen. We expect 50% mortality. It doesn't matter what you do. It won't be about you being a bad nurse or a bad doctor. That's what it's going to be like. By the way, it does not work to pre-screen for psychological suitability to work in a stressful environment. You might psychologically screen for any other number of reasons, but see who will do well or won't do well. You can't do it at this point. But what you can do is you can be frank and you can be honest and you can provide information. We buddied people up. That top left, that's not the Nightingale. I actually couldn't find one of the pictures. So if you remember, that was the height of the pandemic. They had the full PPE. That wasn't masks. People were going in completely kitted out in that kind of space kit. And these were new teams, so they also didn't have the luxury of having met each other before. So if you imagine going in tomorrow to a team, but everyone else in your team is completely new to you, you've never met them before, and you're all masked up, you can only see their eyes. You know nothing else about them. So we buddied them up, so you're told this person is your pair, you've got to check in on each other throughout. We had to have names written across, and you had a job to check in on your buddy. And what we did in the bottom was we would check in, we would debrief them at the start and end of sessions. We would have conversations with managers about watching for presenteeism, where staff are sitting there and not engaging and not talking. The personalities vary, so sometimes I'm an introvert, so sometimes people may not want to talk. So there's variation within it, but trying to keep an eye on your staff and having managers who we called psychologically savvy, who are thinking about the workforce, thinking about who might be struggling. So that's primary prevention. Secondary, we had a team of what we call welfare workers. That's them in the Excel behind me. And actually, they were furloughed staff from EasyJet. Are there any EasyJet staff here today? Used to be. They're the best. I tell you what, I've decided if I want to get staff in to check up on my staff, I get aircrew. They were wonderful. So part of the issue was it might be more difficult to come talk to a person like me. So a guy in a suit, I don't know how it comes across to you. I hope I'm approachable and friendly, but you want folk that your team can talk to. The staff there behind us, the welfare workers, they had very identifiable t-shirts, they had identifiable lanyards, and we told folk at the start, they would just walk the floor, they would drop down, they'd have coffee with people. If you didn't want them there, they'd go. I mean, they weren't trying to be too intrusive, but it was having very accessible means to access care. You didn't have to, knock on doors, you didn't have to phone up. You had people who would come and check in and say, how are you doing? And it was okay to say it's just been a bad day. I remember being a junior doctor and someone said that, a more senior doctor said they were really struggling that day, and I thought, I didn't know you could say that. So I was kind of trying to normalise the fact. We had posters up, it's okay to not be okay, and to have folk that you could talk to. And then tertiary prevention, that's part of the mental health team. We worked on a model called PIES. This is when you actually had a problem. You went in and said, I'm feeling anxious, this is not normal for me, I'm feeling depressed. So the PIES was proximity, so we're close by. Now, I appreciate you can't do all these things necessarily in industry. What I'm trying to do now is see how much I can translate to a contemporary NHS setting. In the Nightingale, it was an unusual place, but we could, in a weird way, we could do what we wanted to. We were freed up. All bureaucracies cut through. They said, do what you need to do and do it now. So proximity, we were in the middle of it. In the middle of all those wards. There was immediacy. You did not need to book. You walked in and we were there. The E was expectancy. Our expectancy was to get you back to work. And that should be the expectancy of all occupational health. How do we help you get back to work? And what is it we need to do to support it? That's our expectation, because work is good for you. And then S was simplicity, keeping it nice and simple. So there's a primary, secondary and tertiary approach to doing it. Now what I'd say to you, I brought up the example of the Nightingale, and the Nightingale was really unusual. It shut down, it was never needed. And that was quite politically controversial at the time. And I've not put the picture up, but we had to hold an event. We held the event for our staff and we closed. We got the O2. It's one of those weird times. You could just say, could we have the O2? And the government would give it to you. And we use it as a venue. Our staff were really devastated. There was a lot of negativity in the press at the time, white elephant, not needed and so forth. And it wasn't. And that's a really good thing. How awful had that been needed? And how awful, I'm not trying to score political points, but how awful had it been needed and we hadn't built it. And the staff who volunteered didn't know what the outcome would be. And we had to do some psychological work to step them down, because a lot of them felt that they had let people down. It was a really complex era. But as well as being an unusual example, what I'd say to you is there's a massive, and I think looking at the programme, we're going to hear some talks on it today, there is an evidence-based approach to looking after people and to keeping them well. These are some specific papers we've done on it. So this is taking the approach from the London Nightingale. I would argue, of course, you might say, I would say this, a lot of this is transferable across industries. How do you have a primary preventative approach and communicate well with your staff with honesty and integrity and talk to them about risks that are real and how you'll help them? How do you have a secondary approach with the staff group who will look after each other and will have a good way of finding each other when there's a problem? And how do you access that tertiary help when you need it? And I'll finish up on this slide. What I'd say to you is, I'm still interested in this because this is my workforce. I need to keep them well and I want to keep them well. And there's a paradox, but there's also a necessity of looking after the mental health individuals. This is just an example of research that's ongoing at the moment. Jamie Delgadillo is a colleague of mine. We're looking at a couple of things at the moment. One was an intervention to see if you give people the ability to craft their jobs. I mean, all jobs have limitations. You can't just go rogue in it. But if you give staff some ability to change their job to better work around them, or if you give a cognitive behavioural therapeutic approach to trying to help them remodel and re-scheme their job without changing, which one works better? Interestingly, for us, our early evidence is suggesting it's better to do the cognitive behavioural therapeutic approach rather than have people changing the job crafting. What I'd say to you is this is industry specific. I'm sure Jamie would love to speak to any of you about the work you might be doing in aviation, but for us it's really interesting. It's pushing us towards actually having support for staff in a psychological way instead. So that's my talk. I appreciate that's slightly different in terms of a different industry. I don't think we're doing Q&A with me, but I hope that is of interest to start your day. Thank you.
One second. Okay, thank you to Professor Tracy. I think quickly what I took away from what you have said is that one key step is having an evidence base, understanding what the scale and scope and type of problem you have is before you can move forward. Now, within our industry, that's a little bit episodic. You can go back to Harvard in 2016. They looked at incidence rates in aircrew. Trinity College Dublin ran a series of surveys 2016 through 22. The Karolinska Institute are either about to or have launched a pilot self-report mental health survey to follow on a previous one. We have some data. I'd be interested in chatting with Professor Tracy later. Our data is from surveys, which are technically called episodic surveys. People volunteer to take part. Places limitations on what you can do with the data from the survey in terms of referring back to a population. I've taken away from what you've said is that getting good quality data is the first step. So as an industry, perhaps that's a lesson we need to ask ourselves. Are we collecting the right kind of data to do the right kind of analysis to feed into our safety management systems? Those of you who know me know I've been banging on about that for a number of years. But I think what I took away from Professor Tracy's talk is that is a fundamental foundation. And so as an industry, we're very good at collecting and analysing data once we decide to collect it. And so that's something I think perhaps we could learn from Professor Tracy's work at the NHS and see what can transfer over. What do we need to do better to satisfy Professor Tracy that we're asking the right questions with the right data? Beyond that, our next speaker, who's probably known to many people. I have a very brief bio, but I can do this from memory, really. But we have Herwin Bongers. He's a senior examiner captain on the Boeing 787 at Air New Zealand. He's an aviation health researcher and mental health specialist. He has worked widely over the last significant number of years promoting mental health and well-being as a core element of operational safety. And for those of you who don't know, Air New Zealand are perhaps not an exemplar, but the approach that they have taken as an organisation to mental health and well-being is one that would be a very good model for a great many other organisations to undertake. So with that, I'll hand over to Captain Bongers. I can see you on the screen, Captain Bongers, so please feel free to carry on.
Hello and good afternoon, everyone, where you are. For me, here in New Zealand, it's 2:25 in the morning, and it feels a bit like my third waking up from the bunk on a 18-hour flight from JFK to Auckland. So it's all good on my side. I hope I haven't got the post-lunch graveyard shift, so I'll try and keep things moving along. I've got 18 minutes. In that 18 minutes, I'm hoping to present a challenge, and the segue for relevance here was quite noting with what I just picked up from the end of Professor Tracy's presentation. I'll discuss some topics of taboo. We'll have an anecdote, an allegory, and an action plan. So with that, for those of you that have perhaps seen a match of rugby between yourselves and our team of the All Blacks, you'll note that prior there's always a respectful challenge placed before the game, and known as the haka, and it's what we like to do. And so I'd like to present perhaps a cerebral respectful challenge to you all in this regard, and I'll bring up my presentation here for you. So, it segues particularly well from what we just heard. We need to be making sure that how we proceed forward in this emerging era of mental health and safety management systems is based on the right type of data. Now, I do this with an allegory which I think is so sublime that I travelled all the way to Exeter to your National Meteorology Centre to take this picture in particular, and we'll go over this a bit later on. So first of all, let's talk about some of the taboos of aviation mental health. It's important we come off a baseline of equivalence of understanding. And one of the taboos that isn't talked about much is the idea that, and the actuality that pilots and air traffic controllers, we get depressed and we commit suicide. Now, there's certainly sufficient evidence out there, and we just heard about some of those papers around self-reporting events of symptoms of depression that was quite alarming. And with a this is not fact, this is based on corollaries and taking data from different travel industries and looking at our numbers around the world, but it could be hypothesized that globally there is an airline pilot or two each week committing suicide, and for air traffic controllers, approximately, hypothetically speaking, one a fortnight. But then again, this is data we're not collecting. So to put that in relevance, if we were to look at all the commercial flights that have ever occurred since the first from London to Johannesburg there, in the 70 years, there's been over 1.2 billion flights that have occurred. And in that time, when I've asked audiences face to face in the past, I've sort of asked them to indicate to me what they feel is the amount of time that the amount of occurrences of murder-suicide by means of an aircraft where the perpetrator was the captain of that passenger-carrying aircraft. Most people think it's around in the tens or even close to 100, but from a study in 2016, we can actually quantify that as being 6 occurrences. And if we think of perhaps the Malaysian and Air China ones more recently, that number's possibly 8. So when we think about how that sits in an actual occurrence probability, we look at it in the regions of being 6.5 times 10 to the -9. So a highly, highly rare event, but yes, still consequential. And we know how to deal with this in aviation because we take it to a SMS format, we put it in the matrix, and we realize that we deal with it as we would any other moderate risk, in which case we put in place mitigations and controls. We don't spend millions of dollars trying to eliminate the next occurrence because that would be a misappropriation of effort, resources, and finances. So here's a test question. If we look at the situation that as we know, pilot and air traffic controller depression occurs. We know that there are numerous instances where that leads to suicide. Does that correlate to murder-suicide by means of an aircraft? And so the question I ask audiences there is, and I can see you in the room, is raise your hand if you know of a colleague who has been poorly afflicted and ended up committing suicide. It's something that occurs often too regularly in our, but it's kept quiet. And then if we were to have a think about that colleague and then try and categorize what perhaps their state of mind was and what actions they were capable of, could we imagine, keep your hand raised if you could imagine that that person was capable of taking an aircraft with passengers and committing suicide with it? The two don't correlate. The evidence tells us such. And so, yes, we have instances of it occurring in the industry, but the precursive issues around pilot suicide and depression don't automatically correlate to the outcome of murder-suicide by means of a commercial aircraft. So, and yet, we have uncomfortable truths. And this is a very, very good paper published by yourselves, and it characterizes that should we introduce the China Eastern Airlines event, that as an industry as safe as ours, it's possible again to hypothesize that for events of murder-suicide, it has created a scenario where the most deaths in the airline are from that as a source. So let's move on. And when we're talking about data and relevance and what data needs to have as actionable data to then reliably create good policy, we need to think about those aspects. So if we were to think in terms of completeness, in my flight deck, we have a printer roll and we get many of our messages from the ACARS system, and we generate the paper copy in our paperless flight deck. And in that environment, we'll act from and interpret the data that comes across. But what happens quite often is that the paper roll, because the crew that departed the flight deck on their rest prior didn't tell you it was running close to running out, will sometimes run out of paper. And so we end up with information that's incomplete. And so consequently, acting on that can be at times quite troublesome. In relevance categorization of data, then one of the bits of data that we're often dealing with is around barometric pressure, and the consequence of an incorrect set barometric value for pilots there is quite significant, and we'll go on to that in a bit. It needs to be timely. So yesterday's NOTAMs are completely irrelevant. This is a process we'll always go through before even departing, is making sure that the notices to airmen that might affect us in a safety sense are valid, and we'll check the timestamps. And of course, the final and most important is the accuracy around that data. After 23,000 hours of flying, it's the sort of thing that the spider sense often is the savior of the day, because you've seen that before and you're looking at the data and it's not matching what you know to be your experience. And so accuracy is probably the most important characteristic, but the other three are very important in order to be making good policy also. So let's look at our anecdote. For those of you that know this case, the picture tells 1,000 words, but for those that don't, it was a flight from Stockholm to Charles de Gaulle, and the air traffic controller passed on an incorrect barometric QNH value to the pilots, which they placed into their instrumentation. And on a normal precision approach, that perhaps wouldn't be so critical. But in this particular case, they were flying what's known as a baro reference approach, an RAeS, and I don't know if any of you have visited New Zealand. We fly into a beautiful mountainous airport called Queenstown. And back in my Airbus flying days, we would do 4 of these approaches a day, and in amongst mountainous terrain, and the criticality of setting the correct value on the QNH was massive. In this case, the flight got to within 6 feet of the ground, and the point just prior, you may be able to see the wording there, but it says the captain's nose up inputs occurred. Now, I can tell you that was his spider sense telling him something's not right. I'm not, even though all my instrumentation is telling me all the correct things, my intuition is leading me to the conclusion that things are not right. And then at point number 4, he's initiated a go-around engaged toga, and but the flight came dangerously, perilously close to hitting the ground, 6 feet, the height of your average man. So now this is where the allegory of pressure, I feel, is so sublime. So this instrument, and I'm not sure if any of you actually recognize it, is what's known as the tempest prognosticator. And perhaps the best instance of nominative determinism I've encountered, it was invented by a chap called George Merriweather in the 1600s, and its aim was to be able to foretell and predict when bad weather was arriving. Now, if you can perhaps see, there's 12 bottles placed around the circumference, and in those bottles are leeches. And so what Mr. Merriweather decided was that he took the proxy of leech behaviour prior to an oncoming tempest, lowering of barometric pressure, and noticed that they climb and would always go and try and escape, I guess, what they knew to be the rising waters about to come. And these leeches would crawl up the jar, set off a small bell at the top of the prognosticator, and he called it a committee of his friends. When the bells began to ring more frequently, he decided that this was an accurate indication of the poor weather to arrive. Now, in today's day and age, when we're trying to base our judgments and policy off weather and the oncoming of poor weather, we haven't chosen to go with Mr. Merriweather's contraption, and indeed what we have done, and this is one of my heroes, is a chap called Admiral Robert Fitzroy, the father of meteorology, and he established most of your weather observing stations around Britain, and developed the network for understanding and predicting weather. Now, where this becomes a allegory in the sense of mental health in aviation is that if we look at the second taboo I'd like to talk about, is that pilots as a rule are not declaring our states of mental health. And in 2022, Dr. Hoffman came up with a number. He said it was about 56% from his survey that he conducted. And if you talk to most pilots, the first thing they say is, oh boy, that number is way too low. So we carried out an equivalent study in the New Zealand context with pilots and air traffic controllers, and our number came back at something that sat a bit more accurate with those in the know. And then people asked, well, does that just mean that New Zealand pilots are more truthful than American pilots? And to which I would reply, well, truthful about being dishonest in the first place. But perhaps alarmingly, that number, when we titrated the air traffic controllers out, was 80%. And then we asked a specific question about mental health, about those that avoided getting mental health care when they felt that they needed the assistance of mental health care. And for upcoming pilot students, 2 out of 3 of them indicated that they had been in that situation and avoided getting mental health care. If you want to look at the study a bit more, there's, for those of you with your phones ready, if you haven't, don't worry, I'll repeat this at the end of the conversation here. So on to taboo 3. It's a bit of an obvious one, but that's not quite the whole piece, because James Reason told us this years ago. In fact, the part that I really want to highlight is we don't know which mistakes in our industry are caused with a precursive element of impaired mental health. So good, well-meaning practitioners of aviation arriving into the workplace for reasons that we can show later on, with a state of impaired mental wellness, and interacting in an environment where error is so important. So we don't know, with all the slips, lapses and errors, what subset of those are due to impaired mental health. Is it this big, or is it indeed this big? That's something that we need to be collecting the data on. In other industries, here's a study which took 60,000 workplace interviewees, and it found that for instances of moderate psychological impairment, that the odds ratio of errors in the workplace doubled. So, and what was interesting is it was no different for people with higher levels of psychological distress, but perhaps more alarmingly, for actual events of accidents, it was 40% increased the odds ratio. And but is this relevant? Well, actually, in the aviation context, we have many systems and threat and error management programs which have brought our safety levels to such a high standard. So these numbers clearly wouldn't be equivalent in our industry, but it's indicative all the same. So here's some of the reasons, and I must apologise if those that know the author of this graph could perhaps personal message me afterwards, because I am unable to attribute it because I can't re-find it. But it goes over the reasons for non-disclosure around the big winners or hitters, let's say, are fear of license, loss of license, stigmatization by employer. They're all the regular things that you'll probably learn some more about in today if you haven't already. So what do we do? Well, ICAO gives us some guidance. Here's a great manual that they've put out, and it talks about the use of the threat and error framework to understand the relationship between safety and human performance. And using that threat and error management process, then that often then will lead us into how do we dovetail that into an SMS wellness matrix. And if we were to take a similar type of approach and look at it in a mental health context and the continuum. Now, often you'll hear people say in a degree of well, now we're talking about it more. How about we work out, are you in the green today? Well, with long haul flying and with a number of family health events and personal matters, and I can say that on most days, I'm heavily in the lime, often yellow, and then I'm really working on a number of the tools I have to bring me back down into where I can operate quite happily. But there's very few days where I can say I'm fully in the green and Pollyanna-ish going through life, because as Frank Sinatra said, that's life. So this is the area we want to be looking at in our threat and error management. And how are we to do it? If we were to loop back to how we're collecting our data. Now, if you can think of where fatigue was when I started flying, and if we'd suggested in putting in a flight occupational safety report that we would ask the reporter to indicate if they thought that fatigue was a factor in the reasoning behind their event that they were reporting. There would have been scoffs and very little integration. But now we're a number of years later on, and it's almost a factor of well, let me think if I can seriously understand what my roster patterning was and decide if fatigue was one of those factors, and if I can, I will most definitely tick that box. Well, where I'd like to see us go with data collection is bringing in the relevance of self-assessment in the feeling and sense of either being overwhelmed or being distracted into that occupational safety reporting process, and then underneath have a validated questionnaire that can start bringing on data in the realms of degrees of mental health, and associate and collect that data against operational safety occurrences. And in doing so, we can at least then start taking more of an evidence-based approach with what programs we're looking, which ones are actually going to have an impact on addressing where we go from here. So to wrap things up, here's my challenge. I think we need to stop acting on measures of proxy data to address the impact of aviation safety in the impaired mental health space, because for too many years, all it's led to is pushing the knowns down into the unknowns because of the huge rate of suppression of data around mental health state. And perhaps because we're so good at it, what I like to say is we have these fantastic silos of excellence in data collection and safety, in occupational health, and in integrity. And we need to start working out how we can already address those issues with skills that we have in those areas of excellence. And we know that in an SMS context, we have brought in programs, for instance, the upset recovery and prevention training programs that have had a preventative safety benefit. So here's that QR code, and also for those of you that would like to get hold of me and perhaps discuss things further, there's my contacts if need be. Hopefully I managed to get that done in 18 minutes.
I'd say thank you, Erwin. Hope we haven't kept you up too late. Interesting, I think, the key thing, we need the right data. That's what I took away from Professor Tracy's talk. We are lacking that data and even an understanding of what that data should look like and how we would collect it. Interesting you referenced fatigue. I absolutely agree. We are, in mental health, some years behind where fatigue is. If one looks at how fatigue data is collected, two options, the organizational level or the individual level, which can be collected through no financial interest, Jefferson's Crew Alert Fatigue Monitoring app. Do we see a way that we could introduce something similar in an acceptable format? Again, I go back not just for pilots, but for all the safety critical groups, so that we can begin to collect a coherent data set for analysis to determine policy, and also, absolutely, Erwin, get some sense of which interventions work and which interventions don't. So, thank you very much for your contribution today. Thank you very much for dialing in from New Zealand. And I would be very surprised if you don't find people either in the room or in the online community reaching out to you. hopefully you won't regret a deluge of emails asking for information and guidance on certain topics. So, ladies and gentlemen, all the way from New Zealand, Captain Herwin Pondus. So, what we'll be doing now, we are running a few minutes late, is inviting a couple of people to the stage to essentially do a Q&A, a panel discussion. Two people I know very well, but I'll read their bios anyway. Two people who have been looking at mental health in aviation for longer than I have, and people who I respect personally greatly. Professor Robert Ball, Honorary Fellow of the Royal Aeronautical Society, Director of the Centre for Aviation Psychology. Professor Ball is the Director of the Centre for Aviation Psychology. He's a registered and practicing clinical counselling and health psychologist, and also a certified aviation psychologist. Rob is a board member of the European Association of Aviation Psychology, clinical psychologist to the Royal Air Force on the ICAO Mental Health Working Group, Aerospace Medical Association Mental Health Group, and European Pilot Peer Support Initiative Committee. Until 2023, he was the lead consultant clinical psychologist at the Royal Free Hospital NHS Foundation Trust in London, working in acute and clinical care with a special interest in safety in high-risk work settings. He's published more than 35 textbooks and 250 academic papers and chapters in books, including 4 key textbooks in aviation psychology: the Handbook of Aviation Neuropsychology, Aviation Mental Health, Pilot Mental Health Assessment, and Support and Pilot Selection. He's received the highest award in aviation in 2017, an honorary fellowship of the Royal Aeronautical Society, and is listed on the Smithsonian National Air and Space Museum Wall of Honor in Washington, D.C. He's a liveryman of the Honorary Company of Air Pilots and holds the Freedom of the City of London. Rob is a Churchill Fellow presented by Her Majesty the Queen, and together with the Asthma Mental Health Group has recently received the Boothby Edwards Award from the Aerospace Medical Association. So Rob will be here with that CV. I'm sure that he will be able to answer any questions you have. Paul Roysack, Fellow of the Royal Aeronautical Society, Vice President of the European Cockpit Association. Paul is the VP of the European Cockpit Association, as well as the EVP Europe for IFALPA. For anyone that doesn't know, the European Cockpit Association represents the European pilots. I think in the region of 40,000? 43,000. They've obviously acquired a few more recently. He's been an airline pilot since 1995 and is currently a captain on the Boeing 737-700 and 800 for Luxair, flying out of Luxembourg, which he joined in 1996. From 2014 until 2018, he was Director Technical Affairs for ECA. He's been a member of the EASA Germanwings Task Force and has contributed to the task force's final report, and has been a member of the steering board of EASA's Data for Safety initiative. Paul is also involved in the just culture aspects of safety management and was also co-chair of the Director General MOVE's European Industry Just Culture Model Policy Working Group. Paul is also a fellow at the Society here. So with two very, very experienced people, I'd like to invite them to the stage, and we will see if we can't learn some things from them. I'll sit at this end if I may, gentlemen.
Mark, firstly, thank you very much for the warm introduction, Mr. President, and ladies and gentlemen here and elsewhere. Thank you very much for joining. I'm Rob Bohr, and
yeah, I'm Paul. So thank you for having us, and looking forward to a good discussion.
Okay. Can I start off? We'll take questions from the room. There's a roving mic. Anybody online can use the Sligo system. The questions will pop up on my tablet here, and we will try and answer the questions which deliver the best value to people. So I suppose the first question for both of you, but we'll start with Rob. Given the presentations from Professor Tracy and from Captain Bongers, from a clinical perspective, what do you see are the main challenges in acquiring the kind of data that we might need to inform a safety management system in the aviation industry, given its multiplicity of layers and regulators?
It's a great question, thank you. I think we've got to start with something which I think most of us already appreciate and understand, and that is that aviation is a context which to some extent is atypical and in other respects is typical. There are many and related safety critical settings in which people work. In aviation, we have linked the ability to practice, whether it's air traffic controllers, pilots, to some extent cabin crew, and others in the safety chain and in the workforce, such as engineers. We've linked their ability to work with their medical certification. And in so doing, and this wasn't an act to create jeopardy, but we have a challenge, because if your livelihood is directly linked to your having a medical certificate, the incentive to put up your hand and to look for help or to volunteer information in any form of assessment, whether it was according to the cross-sectional surveys that we've heard about, or more in-depth, perhaps narrative-based studies, there are going to be impediments there, because people will tell you what they want to share with you, and they may sometimes exaggerate certain features of it, or they may misrepresent or understate it. I think that is a given. And that is our biggest challenge, both from a clinical perspective, but also from a research perspective. If the incentive to share information is low or potentially could put somebody in jeopardy, they will give you information that they want to share. We do not have in-the-moment checks for, and let me explain what I mean by that, mental health checks for aircrew as they board an aircraft. And I hope we do not move toward that, even though from a market-based point of view, there is interest in such. Create an app where a pilot or a traffic controller reporting for duty would type in or enter a few details about their mental health and well-being, and assuming they pass that, they would then be let onto the premises or on the flight deck or whatever and be able to operate an aircraft. As a clinician, I am aware that from a mental health perspective at any rate, the presentation, the clinical presentation of the individual in front of us is the most important factor or feature about them. We don't have scanners, we don't have blood tests, obviously, and related markers of somebody's health, and certainly in terms of well-being. So we rely on them to step forward. Where there is a disincentive, and we've heard from all of the previous speakers that there is that barrier, then they're not going to step forward. And so that would be one issue, is to lower the threshold or the barrier to help seeking. The other is to make sure that we are not conducting population-based surveys, some of which we have seen, which are asking general questions but are not really tapping into the health and well-being of an individual. Every single person in this room at some point will have experienced some dysregulated mood, elevated anxiety. It may be situation specific, it may be just the nature of our chemistry and other sort of things going on. It doesn't necessarily mean that we were clinically depressed. It doesn't mean that we became actively suicidal. So we need to look at some of these surveys in another perspective and perhaps impose that on top of the data that we already have. We do, I believe, and we're about to start publishing some of this data, have certain proxy or surrogate markers of what's going on in terms of mental health, well-being, and the mental health of some of our air crew. And this is through the mechanism of pilot peer support, which many of you will be aware of. following the Germanwings pilot murder-suicide crash, and we saw a slide from Owen about that, the regulator in Europe required all pilots to have access. They didn't have to access it, but they needed to have access to pilot peer support. Why is this a great innovation? Firstly, it lowers the threshold to help seeking. If you know that a colleague out there who has a similar training and understands your work setting and understands the intricacies of confidentiality, if you know that they're available to speak to you in a confidential setting, you're much more likely to approach them. And we have data from over 1,000 pilots who've accessed this across a wide range of AOCs, perhaps in total 30,000. And some of the data that we're seeing suggests, firstly, that the kinds of issues that aircrew are experiencing, we would probably term to be common mental health problems. So these could be things that are generated by living. It could be the work setting, it could be a command upgrade stress, it could be separation, divorce, ill health in the family, and so the list goes on. And for well over 95% of the cases that we see, these are managed within peer support. They do not reflect deep mental health problems or established psychiatric disorder. So this data will be coming on stream. There are other ways as well to measure this. I think the way forward, just in conclusion, will be in a more narrative way, because if we carry on doing more of these population-based surveys of flight crew, with all the caveats that I pointed out relating to their willingness to participate, or, I know this sounds unkind, to fake positive or fake negative in some kind of way, to distort the result because they are trying to message us in some kind of way, we're going to keep recycling the same data, and we're probably going to see more of that. So actively working to lower that threshold so that pilots know where to access support, that's really important. The average pilot would not know the pathway to accessing mental health support, what would happen next, how long they may be grounded, if that were to be the case at all, whether they have to take medication and more advanced treatments, and whether they'd ever return to work. And for myself as a clinician and other colleagues in the room, it's a given. And we know that well over 97% of pilots with mental health problems will return to the flight deck. But somehow, this is not made aware to pilots, and they do not understand or know how to access the pathway. So a lot of education on those grounds as well. Sorry.
Okay, no, thanks. Okay, the same basic topic, but Paul, in terms of accessing quality data, the kind that the indications are we would need, would that be viewed in the perspective of the pilot community? What are the issues that you, with your ECA hat on and as a pilot, would look at as being concerning in order to allow the collection of the necessary quality data in order to use it in the safety management system?
Yeah, well, good question. First of all, I would like to congratulate Professor Tracy. You know, when you say that, you know, one of my missions is to make sure that my people are well, I haven't heard that from many airline managers. So in my next life, I'm going to work for the NHS. Anyway, yeah, good question. I mean, I agree with Rob that, you know, these surveys that we do, and I just been 10 days ago to the Ghent survey presentation, and I have some numbers now. Rob tells me, you know, they might not be very objective, and we have the Karolinska study, and these surveys, I agree, are you know, have some caveats and some shortcomings, but I think indeed that there is a message there. I also would be great if you could have better data, more accurate data. And you're probably talking about, you know, it's with the modern technology, we're talking about, you know, whatever ActiWatches, apps, you know, some sort of live measurements, and you can imagine that, well, the pilot community as a whole is probably very skeptical about this, because what we see in aviation, unfortunately, is that a lot of these issues, you know, there's, if I may say so directly, there's a couple of bad actors in our industry. And as an example, for example, and Rob, I think you're aware, and I think it's great what we did after German Wings. We have psychological assessments, we have pathways to help, but we also see that in some places, and funnily enough, they're also geographically defined, we have these psychological tests and this psychological assessment being used against people who speak up too much, who report fatigue too much, or who write too many safety reports. So that is always what is on the back of our mind, of our pilot community. And I apologize for being such a negative, having such negative approach to this. But in general, I agree with you. We need to make sure that we find ways to get the real data out, whether it's by technical means, by live measurements, or maybe simply because we can maybe create a psychosocial work environment where people feel valued and respected and can do their work and are not afraid to speak up. So that would be probably where we would push the industry to go.
Yeah. Okay, thank you. Subsequent question then. I'm sure Rob can speak to this as well, but you've been very involved in the Just Culture initiative. Can you envisage a way in which we could incorporate a higher level of trust in the safety critical workforce groups within a just culture framework to facilitate capturing better quality data? What are the things that are stopping that happening in your view?
Oh, well. You have 2 hours? No, I think it is exactly what we need to do. And you know, I will again start bluntly by saying that, you know, in aviation we pride ourselves on, you know, just culture, safety culture, on human factors. And we're actually very bad at it. You know, we're still reducing all of this to 2 things, which is first of all to processes, because we understand processes and checklists, and we reduce it very often to regulatory compliance. And I think that is the issue. We need to look at the fact that, you know, the people in this industry, and from ATCOs to pilots to flight crew to engineers to ground staff, there is a backbone not only of our safety efforts, but there's a backbone of this industry functioning for their passengers and for our customers. And what we need to do is that we need to learn from other industries. We need to move on to create psychologically safe work environments. We need to understand that people are not full-time equivalents, but humans. And if we treat them as such and create the right environment, they will perform, for most cases, admirably. And I think it's you know, last 10 days I've been to 3 events, including this one, where we talked about the importance of people at the center of our industry. And in this room, I think we can all agree to what we say. And there's great initiatives. I mean, if I may, ECA has started this positive organizational safety culture in aviation initiative, where we try to define some cornerstones. I know Harry Nelson is over there. He and some colleagues of his have started this CALM initiative to help with safety leadership. I know of a Lufthansa study that, or project that has been, well, shelved about health management in high-risk organizations. So it's there, and there are people there. What we need is bring it together and create a set of best practices of how we approach the human in this industry and how we make the environment that we all work here the best environment possible, so that we can have the safety and also the economic outcomes that this industry needs.
Thank you.
Can I just add there? Just culture, as I understand it, pivots around no jeopardy. If somebody is willing to come forward and to share some of their challenges or mishaps or behavior that perhaps was not safe in a particular environment, the idea is that we would respect this and we would help the person to either retrain, rehabilitate, or whatever, but it wouldn't impact their employment directly unless there was some other or exceptional kind of circumstance. I think half the problem is not so much just culture, but whether it is being executed in the way that it was originally designed for. And from a mental health perspective, we do have various mechanisms in which this can be addressed. And, I think all of us understand that in safety critical situations, there are behavioral components in almost every aspect of it. It may be machinery that is not working properly, but there is a person operating it. And typically and historically, there's been considerable and disproportionate blame toward the individual without understanding perhaps systemic consequences. Just to put in perspective, where there are collective issues such as fatigue that may be relevant, or let's say an outbreak of bullying in an airline or something like that, there is a way in which that can be fed back. But we do also have much swifter, stepped up protocols for dealing with mental health safety critical issues as well, whether this is preventive, perhaps if there is a crew member known to be behaving in a particular way, perhaps using recreational drugs or alcohol, something like that, that could endanger an aircraft, that can't wait until the safety system comes to meet. That has to be reported. And to the best of my understanding, and I'll touch wood, this seems to work very effectively. But we still need to lower the jeopardy and implement what just culture was about, which is that people will be dealt with with a huge measure of benevolence.
Okay. Fine. Thank you, Rob. I'd like at this stage to throw the questions to the floor and the online audience. If anyone has a particular question based on what they've heard in the presentation or this panel so far, please feel free to engage. There's a roving microphone in the room and the Sligo system for people online. So does anyone have any particular question that they might like the panel to address for them? Okay.
Well, good afternoon once again. Thank you very much for being here, and to our speakers as well. It's a very, very insightful afternoon. I'm a flight instructor. I've done my flight training over in Florida. I'm currently a graduate student at Embry-Riddle Aeronautical University, if you guys know where that is. And we've heard a lot from the sort of in-career sort of aspect, timeline. I'm really interested in the flight training stage. And I was wondering, what expertise could you guys offer to us as flight instructors and educators at the very beginning of our flight training journey, where we can sort of introduce flight students and students in general who are looking to get into aviation to best managing their mental health and fostering a really healthy perspective and notion when it comes to perhaps going through difficult mental health times, accessing mental health care, and getting ourselves back on track from the very beginning of the flight training stage.
It's a really great question, and I think if we get the culture right at people's early stage of career development, it's inevitable that that level of openness about mental health, well-being, problems, challenges that we're going to experience in the course of our career, it'll be modeled and we'll feel safer. I do think it's worth saying that I think a lot of students entering flight schools may have a better sense of perhaps or greater confidence in being able to express things. It may be that part of their school or related university training, if they've already done that, will have inculcated it or at least supported it in some kind of way. There was a very tragic incident at the University of North Dakota some 5 years ago, I think it is now, which really turned things on its head in mental health, in aviation amongst student pilots. University of North Dakota has a massive flight training school. It may be equivalent to Embry-Riddle, I don't know, maybe even a bit larger. And that student pilot suicide led to a lot of soul searching. And that university now has created, and I think it's one of the world's first, student pilot peer support programs, which is used very actively in a different way to what many of us may do in order to access support. A lot of that is online, by text, and so on, whereas for other people who are more mid or later career, it may be that they want to physically talk to someone, meet up with them in person in order to get that kind of support. But they've read the needs of the fellow students, they have lowered the bar, and they have responded to their optimum way to seek help and support. There's only one other way I know to do it, which is in the classroom, to make it a related subject. And forgive me, I'm but a PPL, and in the days in which I went through it, it was, I think, a paragraph in the human factors textbook on about taking your emotional blood pressure and temperature, metaphorically, obviously, and that was about it. And in fact, that's what piqued my interest in aviation mental health, was what are we doing about normal problems and escalated problems that we've heard about in the pilot workforce? So absolutely agreed, it needs to happen earlier on. I think it needs to be part of the curriculum. It needs to be done not with here are the symptoms, but here's why it is important for you to have good mental health, because any degradation to your attention, concentration, could become safety critical. And obviously, we're going to rely on you in the first instance to be the judge of that. So, if you're feeling wobbly, distracted, you're going through life crises or whatever, you need to think whether this is a safe day for you to be operating. So issues to do with prevention and recognition are important, but I would say make it part of the pilot training curriculum so it's normalized.
Yeah, I absolutely agree, and I hope human factors training has come a little bit of a way since I did my ATP. Because again, there's so many things in there that seem to bypass our industry sometimes. The other thing to complement that is I think we need to, we have broken the taboo, so we understand that pilots, contrary to popular belief, are also 100% human. And I think we need to learn very early to discuss this openly, with the new students. If you're a flight instructor, it's the same thing that I try to do as a captain in my crew, whether it's on a normal briefing or whether it's after an event, just make it normalize talking about how you feel, or talk about, okay, I might not be 100%. And getting this macho thing out that was there for at least my generation when we started. And I think that is the way to do it. And I think, looking at my kids, I think new generations are much more open to that already. So I don't know if I'm a good, if I can give you good advice here, because my daughter probably say, Daddy. So no, but I think we need to normalize it. We need to talk about it, and it's okay to talk about it. It's, as you said, it's okay not to be okay. And then, as a crew or as a flight instructor, let's see how we bring this day to an end, or whether we just refrain from flying. I think it's very important early on, because, again, if I can come back to the Ghent study, what it shows also is that the younger generations in all this are much more vulnerable in their professional life to have the feeling that they cannot step back because of their working conditions, because of their contract conditions. So it is important to, early on at flight school, give them the measure of what they need to, on how they should approach this. Yeah.
I'd like to just make a quick observation. An organisation I was working with recently doing psychological assessments for their pilots, their training captain said, would you be able to expand our CRM training to include some information on mental health? Not just, as Rob said, not just here are the symptoms, but what are the implications? Common mental health disorders can increase impulsivity, decrease rule-making, adversely impact judgment and decision-making, and impair communications.
So what they wanted to do was that our CRM has become very prosaic, box ticking. We've lost the human element. We think this is really important. How could we do it? And I was very pleasantly surprised, to say the least, because I thought somebody has realized that the people in the cockpit are human, and that they will suffer, to quote Shakespeare, the slings and arrows of outrageous fortune. If they understand what they are, and they understand the implications for their professional role, they are far more likely to engage with them. Put it in context. So I absolutely agree with Rob. The sooner you can introduce that into the syllabus, the better. And if that can be done at flight school, that would equip people with a level of awareness and understanding that they can build on in the future. So you have their contact details. Okay, so we're getting near to coffee break. Sorry, we have a question in the corner. Yeah, thank you. Thank you, Rob.
Okay, thank you. That's a really interesting talk and panel. And I was just wondering, have you come across any problems where in somebody's culture, where they come from, it's not okay to talk about psychology, it's not okay to mention mental health issues, and how you would think it would be a good way to overcome those?
I'll try and answer that. I'm not sure. I probably have more of a sociological view here. Almost certainly culture is a mediating factor here. Whether it is national culture or other forms of culture, it could also just be culture amongst students in a flight school for that matter. I think a lot depends on consequence. Everyone thinks a couple of stages ahead. If I share this with someone, will it be held in confidence or will I be turfed out of here? And we've heard that there are examples, even in the kind of more grown-up world of people who are employed, where methods, medical or psychological methods, are being used to exit people from a particular role because perhaps they're not liked or they're not popular in some way or they're a challenge to someone else. And, hopefully these are very few and far between. But rumor spreads very, very rapidly. So that could be an inhibitory factor on its own, that people fear consequence. I don't want to name particular cultures or regions. I will say, perhaps in partly half reversing what I've just said here, because German wings happened, in a developed part of the world, the response was quite swift, quite liberal, and is constantly being enhanced. And I think, we have reached a point where all of us accept that, we need to continue to change the culture pervading aviation so that, there is no jeopardy or limited jeopardy when people do put up their hands. There was a study, and you're probably thinking I'm about to refer to a culture, they reported it, I didn't, in China, in which the data there says that Chinese pilots, over 90-something% are very happy in their role with no issues or complaints. I personally find that difficult to believe if we compare and contrast it with the rest of the world, where pilots, forgive me, complain about quite a few things, I believe. It's in their nature, and we expect it. In fact, we really get worried when they stop complaining. But there's a difference about complaining about your salary, your grade, your fatigue, and so on, none of which are pleasant, by the way, but these typically do not inhibit people rolling up to work. I think it's different if people are experiencing something personally inside. So, again, it is linked to the jeopardy of the job. And there are certainly regions, countries, and particular airlines, I would say, where if you were to flag some personal issues or challenges, it could have the ultimate consequence, and therefore there's not going to be much incentive. And that's an educative role for ICAO, IATA, who perhaps are not directly involved always in the flight deck, for regulators, and you know, there are annual medical meetings for these people where they congregate, and hopefully good practice that also illustrates safe practice then becomes a role model and one that we can benchmark against, so that other regions that need a bit of catch-up look upon those of us who maybe developed this a bit further, but by no means have we got to the end point here. We are very modest and very careful in any claims that we make, but they look upon it and they think it can be done.
Okay, we have time for one more question from the floor. Oh, in the corner.
Thanks. Yeah, I'm a bit conscious of the time, so I'll try to be brief. So in the previous talk given by Captain Herwin Bongers, he highlighted that the risk of murder-suicide is relatively low compared to the number of annual flights. However, pilots do have a plethora of mental health support options to deal with their mental health problems. But how about for people in aeronautics and astronautics who work in relatively isolating environments, such as aircraft support staff near the Northern Pole or Antarctica, where the environment is relatively dark and cold, and lack of sunlight can lead to depression, and also astronauts who may be potentially hundreds of thousands of kilometers away from Earth, where they are isolated from human civilization as a whole. So my question is, for those that are working in remote and extreme environments, are there any approaches being explored and used to support them, especially considering that their support options would be relatively limited, and if they do develop a mental health issue, it could jeopardize the survival of their crew members and the entire mission, and the environment can increase the chances of them developing mental health issues?
Wow, what an interesting question, a great question, and that gave me 3 seconds to think. Firstly, there is some expert advice here. If you look back at 2 issues ago of aerospace medicine, there is guidance for people who facilitate space discovery and for astronauts and so on mental health considerations. And as we appreciate, and I'm not an expert in this area, even though I'm an aerospace psychologist, I don't operate at that altitude. There are considerations which start obviously with selection, because you have to be quite an exceptional person. I didn't say special, but you know, you need to have certain strengths, talents, attributes, track record, past. Oh, axiom in psychology: past behavior typically predicts the future. Not always, by the way, as we can see. However, their guidance is really excellent. So selection is a very important component. And as we know, training in these exceptional environments, whether it is to extreme environments still on Earth, such as the Arctic, Antarctic, and so on, there is longitudinal training and observation of people in situations that resemble what they're going to experience over that timeline can sometimes reveal traits and behaviors and things like that that perhaps would not work well in the group. But you're absolutely right. The risk and the danger does present, and the limitations for treatment and intervention may be much reduced. In fact, I understand one of the holding points in a Mars mission is exactly that. Firstly, the crew are potentially unlikely to return, I understand. It's a one-way mission at this stage. And secondly, if anything were to happen on board on the outbound, how would they manage it? And they do, by the way, rehearse these situations, because it's going to be a group of people making a decision. This sounds like a reality television program in the making, and perhaps we'll get to see that. Treatments ranging from ketamine to tying the person to the chair, etc. Anyway, it's getting a little bit out of my area of expertise, both of those, by the way. However, the point that you're making is a very good one. Returning to Earth, it still remains a challenge in civil aviation and in other areas too. The pilot motor suicide crashes are very few and far between, and we've looked at the 8 or 9 since the late 1980s where these have occurred. They're all incredibly tragic, very sad, obviously. Often the motive is to try and bury the evidence of what's going on, but with a psychological autopsy, usually 2 and 2 can be put together, which is why we can surmise about some of them. Pilot suicide is more common and obviously a tragedy as well. But if it doesn't involve other people, I think we can get our head around it a bit better. When a pilot deliberately acts in this very destructive way, obviously we need to get to the bottom of why that's happened. But in terms of learning about other and extreme environments, there is ongoing research here. But have a look at the journal Aerospace Medicine.
Cognizant of time, I'd like to give Paul the opportunity. You mentioned isolated environments, limited access to support facilities. Paul has been involved looking at the concept of single pilot operation in civil airlines, where we are going to, if we're not careful, take a pilot and put them into an isolated situation. They may be doing a transoceanic flight and they're on their own in the cockpit. So as an isolated environment and issues around mental health and support, do you have any thoughts on what challenges that poses and how, if in your view, it might be addressed?
Good question. I mean, it's probably pretty interesting for everyone involved if you're alone at 2 o'clock in the morning over the Pacific and you start thinking about that divorce and futility of life. So I don't know, but it is certainly an issue that if we come to that point, and you'll understand that I hope it's as far as possible in the future, we will have to have a totally different look at how we recruit people, what kind of attributes we would need for them, because that is the issue that we have in our industry. We reduce everything to a technical solution. And we forget again that, the human, there's a lot of things where we don't have technical solutions for human behavior, for how humans feel, what humans need to perform to the best of their abilities. So, I cannot give you a definite answer, and I'm probably confusing you more than I help. But I think that is something that would need to be looked at a very peculiar way, and certainly not with the approach that we have right now for multi-crew operations.
Yeah. Okay, great. Thank you, Paul. Sorry to put you on the spot, but isolated people are not just on space missions. As Paul mentioned, it's a long way across the Pacific if you're the only responsible person in the cockpit. Isolation in that sense, you may as well be on a trip to Mars in many ways. So we need to be careful. We need to, as Paul said, recognize that at the center of our industry is the people. And we need to be very careful about making fundamental changes without taking due regard of the capacities of the people we have now and the people who will be coming through the training program over the next 10 or 15 years. Any of you have children under the age of sort of 22, 23, they are bordering on a different species. So we need to change that. With that, I'd like to thank Rob and Paul for sitting here and discussing some very interesting perspectives on where we are going in civil aviation with mental health. So I'd like to say thank you to them. We now have a coffee break. If we could be back by 2:05, it says on the program, give or take a minute or so. We will carry on with the second panel discussion. And thank you very much for your questions. Good afternoon, ladies and gentlemen. We're about to start the second panel discussion. I hope you all had a decent break and a cup of coffee. Standing on the terrace, I was just suggesting, it's such a nice day out there, I was just asking if we couldn't do the second session outside. Unfortunately, the technology doesn't allow it. So what I'd like to do now is to introduce the panel members for the second session. We have 3 contributors this afternoon, Lisa Ward, Maeve Waite, and Nav Kainth, if I pronounced it correctly. If not, I apologise. So I'd like to briefly introduce them and then ask them to come up onto the stage, and then we will start looking at the issue of investing in well-being and mental health. How do we create value for our organizations through our people? What can we do? How do we persuade people that it's worthwhile investing in mental health and well-being? We live in an industry, we work in an industry which is generally very cost conscious. I remember the old joke, how do you make a small fortune in aviation? Start with a big one. So this is a crucial part of the discussion around mental health and well-being. So we're very fortunate to have some people to talk with us this afternoon and answer questions. So Lisa Ward is the head of health and well-being at Heathrow Airport. Lisa is the head of health there, where she leads a dedicated team in developing and executing a holistic, people-centered well-being strategy. Her approach integrates physical, mental, and organizational initiatives designed to enhance colleague health and enable them to thrive at work. She's worked within the aviation industry for over 20 years in a variety of customer and colleague experience roles. I can attest to Heathrow. I was fortunate to be invited to be their keynote speaker at their 2023 Safety Week, and was talking about psychosocial risk management and how important it was to the safe functioning. I was surprised to be told that at Heathrow they have 500 or so companies on their campus every day with people employed by those companies. So Heathrow have done a very good job in moving ahead of many other sectors in civil aviation. So I'm looking forward to hearing what Lisa has to say. We have Maeve Waite. She's a wellbeing consultant and work psychologist at the Civil Aviation Authority. She's currently working on the wellbeing consultancy role. She leads the authority's wellbeing agenda, working across the organization, providing expertise and guidance to facilitate a positive culture of well-being. Her role spans across strategic, operational, and people support elements of well-being, working with colleagues at all levels to embed the key principles and influence change across the business and further into industry. Maeve has worked in the wellbeing field for nearly 10 years across multiple sectors. She's a member of the British Psychological Society and the Psychological Society of Ireland. Nav is the CEO and co-founder of Athera. He's a captain, a commercial airline pilot for a major flagship carrier with nearly a decade of training and evaluating experience as a check captain on both the Embraer 190 and the Airbus A220. Nav is also the CEO and co-founder of Athera, a Toronto-based mental health startup focused on transforming how high-performance industries like aviation address workplace wellness. Motivated by the tragic loss of a family member to suicide, he's become a dedicated advocate for mental health in aviation. So I would like to invite them up. One final thing. Through Athera, he's pioneering data-driven, words we've been hearing today from a number of speakers, wellness programs tailored to the specific needs of pilots and aviation professionals. With his dual perspective as a pilot and a tech founder, Nav bridges frontline aviation experience with innovation to reduce stigma, improve accessibility, and deliver measurable results for pilot wellness. So with that, I'd like to invite the three people up to the stage. So just as a starter for 10, for all of you, I mean, the topic of this afternoon is investing in well-being and mental health, creating value for our organizations. An area where you're all active. How challenging has it been to persuade the organizations that you work for or organizations that you work with to make financial investments in mental health and well-being? And what, if any, suggestions would you give to somebody who's thinking of engaging with the challenge in the organization they work? So if you go away first.
So, hi everybody, I'm Maeve Waite. I had the sort of fortune, I suppose, that when I joined the CAA nearly 4 years ago, there was somebody who had already been in my role before me. So the organisation had already invested in not only setting up a wellbeing consultant role, but also various different resources as well. So that was lucky for me. But I think something that the CAA had done previously and have continued to do since I joined is that we've had a continuous sort of program of various different awareness raising events and really starting to talk about the taboo subjects around. I know we talked a lot about suicide earlier, so we do a lot around suicide prevention as well. But we've also had the buy-in from our senior leaders. One of our EXCO members is actually our wellbeing sponsor. We have a wellbeing board within the organisation, and he chairs that as well. And so we do report into our EXCO on a regular basis, and we do have that buy-in from EXCO. As I said, before I joined, they had already made some financial investments in various different programs. And I think probably the piece of advice that I would give to anybody who's trying to encourage that in their organizations is to speak the language. Try to understand what it is specifically that the decision makers will be concerned about. What are the challenges? How might we overcome those? What's the return on investment going to be? But also what is going to be required of them as a decision maker or as a senior leader in order to actually make this initiative effective? What do they need to do to show up to make that effective? Whether that's, their own attitudes, beliefs, etc., their own behaviors, and actually kind of promoting a little bit of self-awareness as well to make sure that people do understand where they can help that be more embedded into the organization's culture as well in a consistent way, and sort of looking at it through the lens of building incremental gains as much as just shoving something in and away you go, that's great. It's about showing up consistently, regularly, and also holding people accountable as well.
Okay, thank you, Maeve. Lisa.
Thank you. So I can relate to what you said yourself, Maeve, as well. So I feel very fortunate. We have a huge amount of support and backing from our senior leadership team, which is extremely helpful in terms of what we're trying to do. We have a lot of our exec members and our senior leadership teams who are openly willing to share their experiences and their stories around mental health as well. So again, just trying to break down that taboo. And I think that's extremely powerful. We talk about it in terms of suicide prevention, baby loss awareness, just general mental health and a number of other topics. And it just creates a real culture of being able to openly share these things. But I think it has been a challenge historically. I think things have got easier over recent years, but it certainly has been a challenge. One report which I think I would recommend, which is of huge value, is a report that was done in 2023 by Business in the Community with McKinsey's, and it was called Prioritising People, Unlock the Value of a Thriving Workforce. And that really starts to articulate the economic value proposition in terms of looking at the cost of poor well-being against the benefits of good well-being, and actually being able to articulate that benefit. So we've used that within our organisation as well, and that's been hugely well received. So it starts to give you some values and numbers around what actually, how can you invest in that and the return that you're likely to get, because it's not just the right thing to do by people, it's absolutely the right thing to do by a business as well.
Okay, thank you. Nav?
Well, thank you for this opportunity. So if you look at airlines in general, I mean, they're spending millions and millions of dollars into health and well-being programs. Largely speaking, they contract those services out to third-party providers. And when we approached corporate wellness executives at the airlines in North America, one of the biggest things that they told us, and one of the bigger challenges, was that pilots in particular had the lowest utilization rates comparative to their fellow employees in other departments. And so we really wanted to take a deep dive and take a data-driven approach to tackling this problem. And so we wanted to go to the source and go to pilots and find out exactly what they're experiencing, what their issues were, and why that they weren't engaging in company-sponsored resources. So we found some very, very telling information about what pilots are going through, heartbreaking information. I mean, pilots are suffering in silence every single day. They're not getting the resources that they need for either fear of stigma or fear of losing their medicals and licensing. So it was a huge problem. And the executives know that this is going on. And so we sought out to send a anonymous pilot survey, which was grassroots in nature. We didn't put any marketing dollars towards it, but all we told the pilots was that this was being built by pilots for pilots and to try to obtain this data. And so we collected this, and what we're doing now with that data is creating customized pipelines of mental health resources that are specific to the needs of the pilot group itself. And so if we can do that rather than what's being done now, which is just generic resources being provided to employees, if we can actually understand what they need and build resources according to their needs, we'll have higher success rates. So we had incredible amounts of engagement from the pilot groups that we had interviewed and surveyed. And so now we're just trying to partner up with pilot unions in particular to get the help the pilots need and to deliver that help. And so that's how we can show ROI, because the basic information that you get from general EAPs is just usage statistics, which that in and of itself is not a key indicator of effectiveness of the program. So we want to show that through pre and post wellness assessments from the therapists, as well as anonymous surveys of the actual pilots who use the services, whether it was effective or not. And that way we can go to these airlines and say, okay, these are the number of pilots that use your service and what was the success rate from the dollars being invested. So I think it's critically important that we start taking a bottom-up approach versus a top-down approach and find out what the actual specific employee groups need and then build resources according to those needs as well.
Okay. I'd like to pick up a question from the online Sligo for all of you and concatenate two questions. What role could the regulator take in creating a simple rule that would overcome the reluctance of people to engage with the services, particularly with pilots, but also obviously other stakeholder groups? If the resources are there and people are not using them at the rate you would hope, what role can the regulator play in encouraging people to do that? So should we start with Nav, see if you have a view, and we'll work the other way.
Sure. So I would think from the perspective of the regulator, it would be helpful for them to lay out the landscape of what happens, in particular with a pilot. If they do, disclose whatever issues that they're having, if they actually tell us what the consequences are or aren't, then pilots would be more inclined to speak up. Because right now, there's a fear, and I'm sure there's a documentary out called Lie to Fly, where pilots are actually being encouraged to lie about their mental health concerns for fear of losing their medical and licensing. And so I think the regulator plays a huge role in this in being an advocate for the pilots. I mean, ultimately, we're seeing a change when it comes to the discussion of mental health in aviation. So I think it's critically important for them to communicate the changes that are being made in more of a positive way. And additionally, if we can have the regulator working with pilot unions in particular, who are inherently advocates for pilots themselves. So if we can start marrying together, the airlines, the regulatory bodies, as well as the pilot unions, I think we'll have some greater success in having these pilots come forward and getting the help that they actually need.
Lisa, how have you found this at Heathrow?
So I think it's just continuing to remove the fear. There absolutely is fear there, and that's not easy to do, and it's not quick to do. It's a culture change, and that takes time. So I think it's about keeping your foot on the pedal, being relentless, not that continuing to tell those stories, because I think there is real power in people talking about what they've experienced and the support they've got, and those strong cases there. That's been really, really, really helpful for us. But I think also what we could do is around how can, across the airports, and I know we've had conversations around this, how can we come together and have the mental health charter, for example, and really set some of those standards that actually collectively we come together on, reducing that fear, reducing the stigma, and just really helping people feel able to open those conversations and be honest about how they're feeling.
Okay, thank you. Maeve, you have a view, as the CAA representative, you have a view.
No, I do completely agree with what the others have said. I think, it was quoted earlier that 97% of pilots who do raise that they have mental health issues do return to work. And that is something that I know many of my CAA colleagues are very keen to make sure that that message does get out there. And that is, to your points around, it's that transparency piece, and it's the reassurance that actually, speaking from a regulator here, that we are here to support. We want you back in work. We want you to be there and to continue in this industry. And I think also, speaking from my perspective, my role is an internal-facing role rather than an industry-facing role. But I do also believe that part of this is that we, as a regulator, being role models for the industry in terms of how we talk about mental health and well-being, both internally and externally as well. Because I do think that that creates a ripple effect. We have so many of our colleagues who are working very, very closely with industry in all sorts of different ways. And it's about making sure that, if we kind of quote unquote get it right internally first, then that can only have a positive effect going outwards. And again, as Lisa said, it is a culture change. It takes time. Already it's been noted today that younger generations are having and taking a different approach to the conversation around mental health and well-being, and I think that that will continue. The events such as today, I think, are really, really encouraging in this space. But I think it's a combination from a regulatory point of view of making sure that that transparency and that open communication and collaboration with members in industry and coming together, as Lisa mentioned as well. But also internally, making sure, we're practicing what we preach. We're doing it with integrity too. And there are so many different factors that are involved in that, as some have been mentioned here today as well. But I think it's also we as a regulator holding ourselves accountable as much as anything else.
What I'd like to do is take one more question from the online audience and then actually throw the questions open to the floor to see where the audience would like to see the discussion head in terms of topics that are relevant. So the question I have here is one which I have had many discussions with airline executives, and it was how do you persuade people that investing money in mental health is a sensible investment for a business? How do you demonstrate ROI? What reluctance do you face when you're trying to explain that to people? So can we start with you, Lisa? Presumably you have to justify spending money at Heathrow.
So yeah, there's always a business case that needs to be found. But I think what I've also found is doing some pilot programs as well. So before we do anything big in a broad launch, it's about let's pilot it with a small group, let's get the evidence, let's get the data, and then position that back as a bigger program. So we currently run a program called our Senior Leader Wellbeing Program. It's a proactive program. Individuals will participate in an online survey which looks at their wellbeing at home and at work, and then they have a debrief on a one-to-one basis with an accredited coach. They have initially one session, they can have as many sessions as they like, but it allows them really to have a safe space to really think about what's going on for them, understanding what's happening from a both physical and mental health perspective, understanding around balance and boundaries, workload, all of those kind of things, and then speak to somebody who's kind of completely separate, if you like, about what's going on for them. And we piloted that with a small cohort, and it went down extremely well. The feedback, qualitative and quantitative, was exceptional, and therefore we've now rolled that out across the business as well. So I think for me it's around don't be scared to give something a go. Yes, start to build the evidence and say there's a need here. We identified that actually when we spoke to some senior leaders, their mental health had declined from kind of thriving to getting by. So that was enough for us to go back to the business and say, actually, there's something here we want to explore and do something with. Because it is about safety and it is about making safe decisions. And we need people to be in the best possible mindset in order to do that.
Okay, thank you. Nav?
I mean, just to add to that as well, I completely agree with everything you're saying. When we approached the corporate wellness executives at these airlines, the biggest thing they said was, show us the data, right? If you can go to the pilots group and show a boost in utilization rates, then you can actually show us the numbers and it actually works. And that's in a group that's totally untrusting of these types of resources. And so that's what we sought out to do, was show the use case, that improve the use case, more importantly, show them the numbers actually work, that the engagement levels are there, and more importantly, that they're getting the help that they actually need and making a difference. So I think the proof is always in the pudding. You need to have the numbers to back it up, and I think that's what we're doing to present to these airlines, to tell them that it is worth the investment dollars and the expenditures, because it's a lot. And this stuff does not come cheap. But the consequences are even more costly. I mean, we've had discussions over the break about aircraft accidents. There was some great discussions early on in the first panel about the negative consequences and the cost behind it of, pilot suicides and safety incidents that occurs. Like you can't put a price on that stuff, and so it's difficult for us to actually show that if you put in $10 here, you can save $1,000 later. But if we can show the utilization rates, I think that's the biggest driver to encourage executives to put more funding in this space.
Okay, I'd like to switch to Maeve and say, from the CAA's perspective, how could you encourage operators to make the investment? Would you see it as an encouragement, guidelines, or a regulation? Does the CAA have a view on that?
What a question. I can speak from my own professional opinion rather than on behalf of the entire CAA, but I would say you've obviously got things like you've got the employment legislation, you've got the duty of care. All of that speaks for itself. Organisations know that, and operators are bound by that same legislation as much as any other organisation. So they do need to demonstrate that they are going to be showing and that duty of care, and they've got those mechanisms in place to do so. So that is something that I would suspect that we as a regulator would expect of operators and airlines anyway. I think in terms of whether it came down to regulation, I think what I would ask the question would be, how would then we regulate that? What would good look like? How would we measure success? Would we do it between operators, within operators? The nature of this work is that it is incredibly subjective. What's our remit as the regulator here in terms of how much information do we need to know? Because obviously there are confidentiality concerns and all of that kind of thing which do need to be protective. There's a lot of ethical concerns that would need to be considered as well. So I think if it was going to be, I'm not saying yes or no that it should be a regulation, because I think it's quite a complex issue, and I think that there are lots of factors that would need to be considered in terms of how is that actually addressed in practice, first and foremost. And again, as we've already mentioned, as the regulator, we've got to be conscious of the fact that, there is still that stigma, there is still that fear that's already been articulated today. The data that potentially might be sort of shown to us, shall we say, what would we do with that? How can we engender trust between us, the regulator, and the operators as well? And again, if colleagues in those operators know that data is going back to the CAA, then obviously that's going to have an impact too. So I think if we're looking at it from a regulatory perspective, we'd have to be very crystal clear with what data are we asking for, why are we asking for it, what are we doing with it as well? Because ultimately this has very real life impacts on individuals as well. So I think it's not a simple answer. There's lots of different factors that would need to be addressed.
Okay, thank you. What I'd like to do is see, are there any questions from the floor that people feel they would like an answer to? Okay, we have a question here.
Hello, my name is Paul Watts. I'm Head of Flight Operations for the National Police Air Service. So we operate aircraft, all single pilot aircraft and helicopters, and 80 pilots. And my question is, do the regulator, the CA, realise what a challenge managing pilot mental health from a regulatory issuing of licenses perspective is? Because certainly my experience of the last few years is that I've had several pilots raise mental health issues, and I think it's a very brave thing to do because they're instantly grounded. Several months later that they might get an operational multi-crew limitation, but there's absolutely no clear path back to flying. I'm interested to hear the 97% do get back, but actually 0% of the pilots that are presented to us have got back because the process has taken so long, and we're a publicly funded organisation spending public money on salaries. We can't wait for years with no kind of a realistic timescale of what we're looking at, and pilots simply just exit the organisation under the processes for medical capability. And do the regulator realise that challenge, particularly for single pilot operators?
Thank you. I'm going to take that question. To be upfront, my role is an internal-facing one rather than an industry-facing one. So I'm going to be completely frank with you. That question is probably better directed to other colleagues who are here today. So I'm very happy to liaise yourself with them after this. But for what I can add to answer your question, in conversations that I've had with many colleagues across the piece at CA, this is something that they are very much aware of. This is something that they are looking into in terms of how they can improve that process, how they can quicken that process of return to work. And from a people and culture, HR type perspective, it's a very similar issue that we see in any sort of return to work program. I appreciate that there is specific nuance within the aviation industry, but in terms of particularly for pilots as well. But in terms of the principles around a return to work process, it is not a straightforward process. It is complicated and it is influenced by so many different factors. Obviously, at what stage was there intervention? Was there any intervention? Was it just somebody was left to struggle and then they went off sick? What were the different factors involved? Was it work related? Was it non-work related? What can be done in terms of those different factors? How can we support them? Whether it's work related, how much control and influence do we have on that? And so on and so forth. So it's not a straightforward process, and I don't want to speak for my colleagues who are industry facing, who are here today, but I can certainly empathise with that process in terms of getting people back in work. And obviously, the research does say that the longer somebody is off work, the harder it is to get them back in as well. So, I would definitely say that we as a regulator are very much conscious of this issue, not least because, we've seen it internally ourselves. So it is something that, in terms of our processes, I know that my colleagues are very, very aware of and are looking at what they can do to try and mitigate that process.
Thank you. Can I just expand the question in terms of return to work? Lisa, you run a very complex operation at Heathrow. How does Heathrow manage return to work in terms of representing it as a process and a practice to the workforce? Do you have a clear way of articulating that to people on a sort of a campus-wide basis?
So my role is primarily just within Heathrow, so for the 8,000 colleagues at Heathrow. So within my role, I manage occupational health as well. So for that cohort, it's very much around helping people get back to health and then back to work. So ultimately, it's about their health and that priority. We do have a number of processes and policies. I work within the broader health and safety team, which is actually part of the people and HR team as well. So actually that allows us to have really strong alignment when we're looking at kind of any changes to policy or processes that's needed. So ultimately it's about trying to get people seen as quickly as possible when they're off. We know around the early intervention piece is so important. That's managed through our OH provider, but we also have a number of products and services internally that people can use as well. So it doesn't all have to go through occupational health. It very much depends on a case-by-case basis about what their needs are, and we have the ability to refer people on to specialist mental health support if that's needed as well. So we will always look to do that if that's needed.
Okay, Nav, with your experience, how is Athera looking at, and also your professional role, at this process of clarifying and optimizing getting people back to work?
Yeah, and so that's an interesting question that you pose here, and something that we want to take on head on. And I empathize with the question that was brought up and the suffering basically that those two pilots have to go through to try to get their medicals back. And I'm not one to advocate for being dishonest with the regulator. However, we know that it's happening widespread. I'm reminded of a famous politician about a few years ago who during COVID said if we stopped the testing, then the COVID numbers would go down. And so that's almost what's happening right now, is that, you know, pilots aren't using these resources. So does that mean pilots aren't suffering? Well, we obviously know that's patently false. And so if we can create these, anonymous processes for them to get and enable the delivery of healthcare, then at least they're getting the help they need. And so I think it's a multifaceted issue here, right? Because we're dealing with companies that are profit driven. We're dealing with regulators that have to oversee, tons of different airlines, and then you have pilots at the helm here from a safety related high performance industry. So lots of different avenues that we have to look at. But if we're looking at specifically just the pilots themselves, I would say creating an anonymous resource is the way to go, and we've done that, right? We've seen that firsthand. That it's non-punitive, similar to SMS, which we've well adopted across all industry to great success, and the same type of principle can be used for pilot well-being as well. So I think anonymity is very key to getting pilots on board. Now, again, there's a separate conversation to be had about, being honest with the regulator, but from our standpoint is at the bare minimum at the foundational level is to get pilots the help that they need without fear of losing their license.
Okay, thank you. Any other question? We have a question at the front.
So I guess this question I think is more directed towards Nav, but I'm sure Lisa, maybe you guys can answer it too. As a pilot, we're viewed as numbers. It's a fact. Everything is based on seniority and that seniority number. And sometimes it's very difficult for the airline, the company, and for other people to view the pilots as people themselves. So how do you think, obviously we talked about the regulatory perspective, but you mentioned the bottom-up approach, right? How do you think, let's say, chief pilots or perhaps even lower than chief pilots can implement these kind of very simple but effective methods before the treatment stage and getting help to help pilots feel more like people in an organization and members of a family per se, before we even need them to get to the stage of seeking help? Like I know, for example, my parents are both here today. They're consultants, psychiatrists. They have away days with their NHS trust, which is a really simple way of getting people to just kind of interact. How do you think airlines and airline executives or chief pilots, or even in your organizations, could maybe pitch to management to get the budgeting for these very simple but effective ideas?
So that's a great question. So I would say some of the most effective programming that we've seen from pilots has been through the pilot unions themselves. And so there's a lot of peer-to-peer support networks that have evolved over the years, and pretty much every single airline in North America and obviously in Europe as well that have these peer support networks. And so it's you can relate to another pilot, right? And that's the beauty of our profession, is that we're all in this brotherhood and sisterhood together, and we have a deep understanding of the challenges that we face, the stressors that we face. And so if you can find that commonality through these peer-to-peer support groups, I think that's the best way. Particularly at my airline, in our P2P committee, they take about 15 to 20 calls per week from fellow pilots at the same airline. And so there is an appetite to have this discussion, but we walk the walk, right? And being open and honest about these discussions is a big thing. I've had the pleasure of participating in men's mental health talks, specifically around aviation. And obviously that stigma still exists, but we're eroding it. And that's the beautiful part about what we're all doing even here today, is having these discussions, is that stigma is slowly getting eroded. And having these conversations, especially in a male-dominated industry, being vulnerable helps, right? Creating these peer support networks help. I can speak firsthand. I lost a family member due to suicide. I was going through my own mental health struggles, but I had a phenomenal therapist who understood me, in ways I couldn't even describe, and she changed my life. And so for me, that was an opportunity for me to go speak to my colleagues about it. You know, I'm a check captain, so I'm doing evaluations all the time, right? High pressure situations to begin with, and then you have a candidate coming in who's stressed out about an evaluation. And so I felt it was a great opportunity for me to be vulnerable, right? And sharing my experiences, my stories, sharing also the support networks that are available to them as well. And I thought that really was an effective way to get that human-to-human element from one pilot to the next. And to your point, that's you know, a good baseline from a grassroots perspective, and the change that we can create together.
Thank you. I'd just like to build on that. I think that there's huge value in peer-to-peer networks.
Absolutely.
And certainly that human-first approach. So at Heathrow, we have 2 peer-to-peer core networks. One is called STRAW, which is Sustaining Resilience at Work. So colleagues can reach out at any time and have a completely confidential conversation about anything that's happening, whether that's in work or out of work. And it's face-to-face. They can preference whether they'd like a male, female, within their team, outside of their team. So they kind of really feel in control around how they do that. And then we have TRIM as well, our trauma support service, which we'd like it, if I'm completely honest, to have a higher uptake. But again, we're continuing to try and push that out, to use examples of where some senior leaders have used these services to try and normalise them as well. And just continuing to try and go, okay, how do we make this even more proactive so it's not as reactive as well? So we're continuing on that journey as well.
Okay. Maeve, if you have a view.
I do. I was just going to agree with what's been said. At the CAA, we have similar sort of mechanisms. So, you know, we do have peer networks, and not just around mental health, but around other topics as well. Like we have a menopause network as well. One thing that we've done was that we've mandated mental health awareness for managers training in order to empower and educate our managers to feel much more comfortable around the topic of mental health, to actually start having those conversations, to use their initiative and actually check in, to learn how to spot the signs, all of that kind of thing. So it's kind of, again, it's all these sort of mechanisms working together. It's raising awareness, getting our senior leadership buy-in, maybe to share their own personal stories, or at the very least contribute as to why this is an important topic that we should be paying attention to. Speaking to colleagues across the organisation, encouraging them to share their stories, making sure we've got the right sort of training, learning development type resources as well. And also through our strategy, making sure we've got guidance in place in terms of, you know, standing agenda items around wellbeing, like a wellbeing check-in, maybe at the start of every meeting or something like that. And that could literally be as simple as, you know, score of 1 to 10, how are you feeling today, that kind of thing. In a way that, and I think this was a question that was asked earlier as well, that kind of allows people to feel comfortable to talk about their mental health without necessarily saying the words, if that makes sense. Because again, everybody's starting from a different baseline in terms of their comfort levels around mental health, and it's being aware of that and accounting for that difference as best we can as well. Thank you.
Thank you. Annie, have a question on the left?
Actually, it's Harry Nelson. I chair the Human Factors Group here at the Society. And my question actually leads on from that last answer from Maeve, and I completely agree with you. The question I'm asking myself as a non-academic is, are we doing any service to this whole issue, which is vitally important, by splitting the two into well-being and mental health? If you go to a finance director and say, I've got this program, I want to improve the well-being of my staff, generally they'll find it difficult to refuse. If you say mental health, they go, ooh, hang on a second, I'm not sure. I need to talk to specialists about that. And I just think by splitting it, we're not helping the situation at all. I prefer to deal with well-being. I think it has a much more positive context. That's just a personal view. Okay. I'm interested in the specialist views.
I think that's a really interesting point. I think my observation, not just at the CA, but in a former role where I was doing a similar role, I think that historically, in terms of health and well-being, people tend to feel much more comfortable around the physical health aspects. And so when we think about well-being, that is probably the bit that people still feel the most comfortable for. But interestingly, when you sort of look in the field and you look at sort of well-being professionals and the type of work that they're talking about and the issues they're talking about, they do tend to talk more about mental health. And that's something that I think it's an interesting perspective as well. To your point, I think attitudes are changing. I think people are becoming more comfortable around it because we're talking about it much more. We're educating everybody a lot more now. We don't yet have parity of esteem between physical and mental health. We're in a much better place than we were, say, 10 years ago. You know, the fact that roles like mine and Lisa's didn't necessarily exist across the piece 10 years ago, and in some organisations they still don't. So I think it's again normalising that conversation and educating, and I think particularly for the decision makers as well, making sure they understand what's required of them in order to show up and support these initiatives effectively and with integrity, because that is what sticks. And you know, colleagues and peers, they can see when it's just lip service. They can tell when it's just a tagline and it's just a tick box. And it's making sure that if we can get that genuine buy-in through that education piece, through that understanding, and through that consistent action as well, that's how we kind of start to make everybody feel more comfortable on the topic. And I think, as Nav said, you know, there's definitely a lot of value in the bottom-up approach, but I think we can also do a top-down approach in parallel as well, and making sure that everybody is on the same page and everybody knows what is expected of the individual roles and responsibilities across the organisation, particularly when it comes to wellbeing and mental health. Thank you.
Yeah, great answer. I think for us at Heathrow, we have defined wellbeing as the combination of individual and organisational factors that enable colleagues to thrive at work, and that's actually built into our health and safety policy as well. And within that, we talk about a continuum of care. And so we talk about I take care. So as an individual, you have some personal responsibility for your own physical and mental health. And then as an organisation, we have responsibility to support, enable that, and to ensure that the work that you do in the environment you're in doesn't cause you any ill health, whether that's mental health or physical health. And we kind of have categorised our whole strategy into 4 components, and we call it healthy minds, healthy bodies, healthy work, healthy teams. And then all of our initiatives, our programs, our work is all within those kind of 4 key categories. So again, I think it's just for your organisation finding out what language and terminology resonates and works for your people, so that you can then build your programme around that, and really having those targeted interventions. I think you spoke about that, Nav, earlier. So everything we do is very much around, it's not a one size fits all, it's around actually what different interventions are needed for different parts of the business, for different colleagues at different levels. So yes, we've got some basic principles and some support services, but then there are some specifics there as well.
Yeah, I think, Lisa, you bring up some fantastic points there, and great question as well. I think we've done a great job when it comes to aviation in terms of crew resource management and human factors and the adaptation over the past several decades and the advancements that we've made in that sector. And I think the pilot mental health is now coming to the forefront, and I believe truly that that's going to be the next iteration of human factors and how we view CRM is on the psychological side. And getting that buy-in is of huge importance. And I think where we've seen success is that because we've clearly stated that this is being built by pilots for pilots, that we've had the level of engagements that we've seen and the support that we've received from pilot unions as well. And hopefully that translates now into the airlines and beyond. But I think it's slow and steady, right? I mean, we're making advancements slowly, and I think like events such as these and just having open discussions is what's going to move the needle as we progress forward.
Okay, thank you. Really interesting. We have time for one more quick question. If there's anyone in the audience or anybody online. Okay, we have a question here.
Sorry, I know everyone wants a drink, but I'll try and keep it short. So a lot of the programs that we talk about around investing in well-being tend to be, at least in part, addressing the psychosocial harms that the workplace actually creates in the first place, such as not having enough people, not having the right skills, toxic cultures, bullying, that kind of thing. So a lot of what we're talking about is the programs to kind of address some of those things. Do you have any experience within your organizations of investing in trying to fix the psychosocial harms in the first place? A simple example would be, people are suffering because we need 5 people and we've only got 3. If we spent the money to hire 2 more people, we could fix the problem. Now, I know that those harms are not the sole source of people's well-being challenges, but sometimes I think we invest very reactively when maybe the systems and cultures that we have are actually contributing to the problem.
I can lead with an example I think that might resonate in terms of something that we're currently piloting. So we're looking at a program and it's called job demands analysis. So it's actually looking at each of the roles. So we have risk assessments, all of those things, but actually taking some roles and really looking at it from what is the physical demands of that job and then what's the cognitive demands of those jobs, and really drilling down quite deeply. So spending time with individuals who do the job, spending time with their managers, and then doing job observations to really understand actually from a cognitive load perspective, how much of it is kind of wear versus constant, and then actually how are individuals being able to cope with that, and is it realistic? And then what we're able to do with some of that is kind of go back and say, right, well, are we recruiting in the right way? Are we being realistic around the job previews? Or actually, is that job just too much, and do we need to build something out of that job if we were to do this again? So we started to pilot that at the start of this year. We've done it with about 6 or 7 roles, safety critical roles and operational non-operational roles, and that's continuing to roll out and for us to go even deeper in that. But it's really thrown up some great insights for us to kind of go, actually, let's look at the root cause and what is it potentially that we might need to do or adjust to prevent anything in the future.
Any comment, Nev?
I mean, unfortunately, from a pilot's perspective, there's not a lot that we can change from the day-to-day job. It's more about just identifying the various stressors that we experience. Lots of isolationism, off sleep cycle schedules. Loneliness is a big one. Just the physical demands of being in a flight deck for long periods of time, the fatigue, not only physically but mentally as well. So there's a lot of different challenges that we face. And so I think it's more about just, I mean, if you look at Transport Canada, for example, they're starting to bring in more fatigue science. Even when you come in for your annual medical like this, I just did mine last month, and they were asking questions specifically about my sleep cycles, which I thought was very interesting. So I think that's part of the evolution. But you bring up a fantastic point about, you know, the stressors that the job itself induces for our well-being and our health in general. So I think it's just important to identify what those things are. And then if we can provide programming to tackle those specific issues, then I think we could go a long way with that.
Yeah, so to answer this from CEA's perspective, we have kind of similar processes that Lisa was describing. So we do look at things like job design and making sure that actually we're doing what we need to do, and identifying any sore spots that we need to tweak, we need to change, we need to modify. And obviously that is influenced by the nature of the job in terms of, you know, also the amount of resource we have in those teams, stakeholders as well. So there's a stakeholder analysis piece that comes with that as well. We make use, I know it's not entirely exactly what you're asking, we do make use of stress risk assessments as well, and that's something that we encourage, not just through a return to work process, but as a general kind of, it's good management practice, to be honest. And again, not only does it help with facilitating these conversations, it helps us get to those root causes that are within the work context, so we can actually start to control and influence some of those factors. So it could be that then we look at those in terms of our policies and procedures. Is there anything we need to change? Anything that, particularly if we compare it against our survey data or any of our sort of data we get from the likes of Oc Health, things like that. Is there something that isn't quite fit for purpose, or actually is it giving a slightly different impact that might be good in a different way that we hadn't necessarily appreciated? How can we make that work better for us? So it's kind of an ongoing process of seeing what comes out of it, but it's also making sure that we do have mechanisms for colleagues to feed back as well. And I appreciate that, that has a reactive element to it as well, but also we can use that to then become more preventative in future and sort of turn it around on itself as well, if that makes sense. Thank you.
Thank you. Well, we've reached the end of our day. So before I do some closing remarks, I'd like to thank this panel and the previous panel and the presenters for making today a very interesting and hopefully informative exercise. So thank you very much. Part of my responsibility is to sort of try and summarize and provide some closing remarks. I think what I've taken away from today is a number of things. One, using words that have been here, the issue of mental health generally is becoming more normalized, is more acceptable both to the organizations and to the workforce. It's no longer quite as stigmatizing as it was 10 years ago, but it's still not yet completely destigmatized.
So that's one point that I took away. The second thing I've heard today is the importance of having good quality data in order to make good policies around this. And currently we seem to be in a position that we understand the data we have has got limitations. It's general survey data. It's an opportunity survey, so relating it to the population is more difficult. We need a more nuanced, individually focused approach. How we do that, I'm not sure, but certainly we could learn from Professor Terry and the NHS how to look at that particular challenge. We need to make sure, we've heard the word pilots a lot, and it's an issue. We need to make sure that we recognize all of the safety critical stakeholder groups need to be included, not just the pilots. We should not be, as it were, seduced by the sort of siren song of it's all about the pilots. We have to go more broadly. And so I think if we can build on those points as we move forward, we will approach a more equitable and more effective mental health culture across the industry globally. Now, a bit of a plug for the Society. Last year, anyone who hasn't got a copy of this, which is a document that the specialist group in mental health produced on psychosocial risk management and mental health, it covers a lot of these points. What I've heard today is a lot more detail around some of those points and topics. But they build on the necessity of looking at this both holistically and systemically. Now, on a personal note, wearing my specialist group hat, we started talking to the British Standards Institute about the potential to create a standard around this process. Long way to go, but we are at least having a discussion, which I think is very valuable and interesting, that an organization like the British Standards Institute think that this is worthwhile them considering. I know that they're involved and interested. I'm attending a launch at the Houses of Parliament in about 2 weeks for a suicide prevention standard in the workplace that they have generated. So they have a degree of expertise in working in this space. If we can move in that direction, we may be able to bring all the elements together in a way that is workable. And I think personally, and hopefully for the group here and online, that would be a valuable process to ensure that we are creating a work culture which is positive and supportive of individuals thriving at work instead of surviving at work. And that for me is, and has been for some time, a goal that we should aspire to. So with that, I'd like to thank everybody in the room. I'd like to thank everybody online, the staff at the Royal Aeronautical Society. I'd like to thank Burgess Salmon for sponsoring today's event and making sure that we have coffee and biscuits and things. With that, I was going to show a couple of slides, but I think I'll leave it. I think everyone's probably learned enough for today, hopefully, and hope you all have safe travels home, however far that might be. And hope you all have found today useful and interesting and have made some connections to follow up with for your own specific areas of work. Thank you very much.